Welcome to the Hospital Medicine Unplugged podcast.
Glad to be here.
Today we are undertaking a pretty critical deep dive into an electrolyte abnormality that is just pervasive, really high stakes, and honestly often mismanaged across the inpatient setting. We're talking about hypocalcemia.
Yeah, it's everywhere. You see in the emergency department, on the medical wards, definitely in the ICU.
Exactly. And we've pulled together some key sources, consensus guidelines from the American Thyroid Association, the ATA, and also the Kidney Disease Improving Global Outcomes, or KDIGO, guidelines.
Right, because this really demands a more tailored, evidence-based approach than maybe we sometimes give it.
That's the goal today. To synthesize these guidelines, look at the evidence, and refine how we think about diagnosis and management, moving beyond just sort of generalized calcium replacement.
We need precision.
Yeah.
That's absolutely right. And the sheer prevalence should grab everyone's attention, honestly.
It's pretty striking, isn't it?
It really is. If you look at all hospitalized patients, maybe 15%, give or take, but then you focus on the critically ill, the ICU population.
Yeah.
And those estimates just skyrocket. We're talking as high as 88% in some studies.
88%, wow.
So yeah, our mission today is to cut through some of that noise, pull together what these guidelines say, and try to establish clearer protocols. We need to be precise, like you said, not just blanket replacement.
Precision is definitely the word. And that starts right with the definition, doesn't it?
Mm-hmm.
How are we defining hypocalcemia clinically? And maybe more importantly, why is that distinction between total versus ionized calcium so crucial?
Okay, so broadly, hypocalcemia just means serum calcium is below the normal reference range. Numbers-wise, that usually translates to a total serum calcium less than about 8 milligrams per deciliter.
Okay.
And this is the key, the ionized calcium is less than a 1.1 millimoles per liter. And the immediate takeaway for anyone managing acutely ill patients is you have to measure the ionized calcium for an accurate diagnosis.
Right. Because we see so many low total calcium levels come back, but the patient seems fine. Why is that total calcium often so misleading, especially in our sicker patients?
It really boils down to protein binding. Calcium floats around in three forms, but only about 45% is in that physiologically active, free, ionized state.
The rest is bound.
Exactly. Mostly bound to plasma proteins, and the main one is albumin. Now think about our typical hospitalized patient chronic illness, sepsis, maybe volume overload.
They often have low albumin.
Precisely. Hypoalbuminemia is common. So if your albumin is low, you have less binding capacity. That makes the total serum calcium look artificially low.
Wow. Right.
And if you just rely on that total number, you risk treating what we call pseudo-hypocalcemia. You're giving calcium when the patient's active ionized calcium is actually perfectly normal.
Which is obviously not ideal. Now, what about when ionized calcium isn't immediately available, which, let's be honest, still happens sometimes. We often fall back on that corrected calcium formula.
Yeah.
How reliable is that, really?
Yeah, the standard formula tries to adjust for albumin. It's measured total calcium in milligrams per deciliter plus 0.8 times the difference between 4.0 and the patient's serum albumin in grams per deciliter.
Right.
It's a pragmatic tool, sure, but you absolutely have to treat it as an estimate. Its limitations are pretty significant, especially in critical care.
Why is that?
Well, think about acid-base status. It profoundly affects protein binding. If someone's acutely alkalotic, there are fewer hydrogen ions competing for those albumin binding sites.
So more calcium binds.
Exactly. More calcium binds to albumin, which lowers the ionized fraction, even if the total calcium hasn't changed much. And conversely, acidosis frees up more ionized calcium.
And the formula doesn't account for that.
Nope. The formula completely fails to capture those dynamic shifts. Which is why, again, ionized calcium is the gold standard, especially when the patient's acid-base status is all over the place.
Okay, that makes sense. Let's shift to the bedside then. The clinical picture of true hypocalcemia can range from really subtle to, well, life-threatening. It seems to depend on severity, duration, and maybe most critically, the rate of the drop.
That's right. The rate of decline is huge.
So what are those hallmark early signs, that neuromuscular irritability we hear about?
The earliest clues are usually sensory. Patients often report paresthesias, tingling, numbness. It classically starts periorally around the mouth.
Okay.
And then it often spreads acromially, so fingers and toes. As it gets worse, you start seeing clear signs of increased neuromuscular excitability, muscle stiffness, cramps, maybe spasms, and then the classic presentation is tetany.
And for, our trainees listening, What are those physical exam signs we're taught to look for, the specific maneuvers?
Right, the two classic eponymous signs, Trousseau's and Schwostek's. Trousseau sign is where you inflate a blood pressure cuff above their systolic pressure for maybe 2-3 minutes. And you look for carpal spasm, that characteristic contraction of the hand and wrist muscles. It's basically provoking latent tetany.
And Schwostek's.
Schwostek's sign is tapping the facial nerve just anterior to the ear. A positive sign is twitching of the facial muscles on that same side.
Are they reliable?
Well, they're fascinating signs of increased membrane excitability, but honestly, they aren't super sensitive or specific. A negative Schwostek sign, for instance, definitely doesn't rule out significant hypocalcemia. They're just part of the picture.
Got it. Now, when that calcium level drops rapidly, the stakes go way up fast. What are the really severe, life-threatening symptoms we absolutely need to recognize and jump on immediately?
Yeah, here we're shifting from worrying about tingling to worrying about the airway and the CNS. Severe acute hypocalcemia can trigger intense smooth and skeletal muscle spasm,
Leading to?
leading to laryngospasm and bronchospasm. That can compromise the airway very, very quickly. Patients can also present with seizures.
Seizures, okay. Anything else?
And though it's rarer, the sources mention that severe chronic hypocalcemia can sometimes cause altered mental status or even findings that look like pseudotumor cerebri you'd see papilledema on fundoscopy.
Papilledema, wow. And then there are the cardiac consequences. These always seem the most concerning, especially in critical care, because of the immediate hemodynamic risk.
Oh, absolutely. The absolute hallmark cardiac finding is prolongation of the QT interval on the ECG.
Why is that so critical?
Because a long QT dramatically bumps up the risk for ventricular arrhythmias. Specifically, we worry about torsades de pointe, that polymorphic V-tatch, and potentially ventricular fibrillation, life-threatening stuff.
Definitely.
And beyond arrhythmias, in really severe or chronic cases, you can actually see depressed systolic function, sometimes bad enough to contribute to congestive heart failure.
So this brings us right back to the ICU setting where we said hypocalcemia is incredibly common over half of admissions. The big question then becomes, is this low calcium a direct cause of the poor outcomes we see, or is it more just a marker, a bystander?
That really is the central controversy, isn't it? And the sources push us to be pretty nuanced here. There's no question hypocalcemia in the ICU is clearly consistently associated with longer stays and worse outcomes overall.
But is it cause or correlation?
Well, the prevailing evidence right now suggests it functions more as a marker of severe underlying disease. Think overwhelming sepsis, multi-organ failure, acute kidney injury, rather than being a direct, independent driver of mortality itself. It seems like when the body is under that immense stress, the systems that handle calcium just get overwhelmed.
But we can't just ignore it then, even if it starts as a marker. It sounds like there's a point where maybe it transitions into actually contributing to harm.
Precisely. You can't just dismiss the finding. A really key insight from observational studies is this. Even if the initial low calcium is just a marker, the failure to normalize the ionized calcium level within the first, say, 3 to 4 days of ICU admission, that failure is independently associated with increased mortality, especially in patients who came in with really severe hypocalcemia to begin with.
Interesting. So what does that imply?
It implies that while the low calcium might start as just a consequence of the disease process, if it persists, if the body can't correct it, that signals a failure to restore homeostasis. And that failure likely contributes to a downward spiral.
Okay, that insight really underscores why we need a rigorous diagnostic workup. It should follow a logical, mechanism-based approach, right? So if we find hypocalcemia, what are those initial, absolutely essential labs we need to send off to figure out the underlying cause?
Right. We generally classify the causes as either being parathyroid hormone or PTH mediated versus non-PTH mediated processes. And that framework dictates a specific initial panel.
Built on it.
You need serum total and ionized calcium, albumin, phosphorus, magnesium, creatinine, an intact PTH level, and a 25-hydroxyvitamin D level.
Got it. All of those.
Every single one. If you miss any piece of that puzzle, you're basically flying blind trying to figure out the why.
Let's focus on that PTH level for a second, because it seems like the real pivot point in the whole diagnostic algorithm. How should PTH respond to low calcium? And what does it mean if the level is, well, inappropriate?
Okay, so in a healthy person, hypocalcemia should be the strongest possible stimulus for the parathyroid glands. Calcium drops, PTH should shoot way up.
To try and fix it.
Exactly. PTH tries to correct the deficit by telling the bones to release calcium and the kidneys to reabsorb more calcium. So if you have a patient with hypercalcemia and their PTH level is either low or maybe even more tellingly in the inappropriately normal range.
Meaning it hasn't gone up like it should.
Right. It hasn't responded strongly enough to the low calcium stimulus. That points almost definitively toward hypoparathyroidism, a problem with the gland itself not producing enough hormone.
And conversely, what if the PTH level is elevated? That suggests the gland is working overtime, but something else is wrong.
Precisely. An elevated PTH in the face of hypocalcemia suggests a couple of main downstream failures. First, maybe PTH resistance, the classic example being pseudohypoparathyroidism, where the end organs just aren't listening to the PTH signal.
Okay.
Second, it suggests the PTH is elevated as a compensatory response to some other secondary problem. The big ones there are chronic kidney disease, where you have impaired vitamin D activation leading to ongoing calcium deficits, or just profound, simple vitamin D deficiency itself. The gland is trying, but the building blocks aren't there.
Okay, let's break down the causes into those 4 big functional buckets, starting with decreased PTH secretion. You mentioned hypoparathyroidism. Is surgery the main cause we see in the hospital?
It's definitely the most common scenario we encounter. Post-surgical hypoparathyroidism, often transient but sometimes permanent, after thyroid or parathyroid surgery where the glands might get inadvertently damaged or removed.
What about non-surgical causes?
Beyond surgery, you can have intrinsic gland failure, maybe autoimmune destruction, certain infiltrative diseases, or you can have functional suppression of PTH release.
Functional suppression.
Yeah, and the most critical one we absolutely have to check for and fix is hypomagnesemia. Magnesium is essential for PTH release.
Ah, the magnesium connection.
Right. If magnesium levels are too low, the parathyroid glands simply cannot secrete PTH properly. It causes a functional hypoparathyroidism. Severe hypermagnesemia can also do it, but low magnesium is much more common.
Okay, that links nicely into the PTH resistance category you mentioned, with pseudohypoparathyroidism being the classic example.
Yeah, that's a rare genetic condition, but it's the textbook case of end organ resistance. The PTH level is there, often quite high, but the kidney tubules and the bone cells just don't respond effectively. They can't mobilize calcium or reabsorb it properly.
Then our third category, vitamin D deficiency and abnormal metabolism. This seems like it must be incredibly common in the general hospital population.
Oh, it is absolutely rampant. Vitamin D deficiency is a huge contributor, especially in patients who are malnourished, chronically ill, maybe lack sunlight exposure, the usual suspects.
And without enough vitamin D.
Without enough 25-hydroxyvitamin D, you just can't absorb calcium efficiently from your gut. But it's not just intake. We also have to think about the kidney's role again.
The activation step.
Exactly. Impaired 1-alpha hydroxylation, which happens in chronic kidney disease, prevents the conversion of that storage form, 25-hydroxyvitamin D, into the biologically active form, 1,25-dihydroxyvitamin D. That creates a really potent functional deficiency, even if the storage levels look okay.
Got it. And the final category, chelation and precipitation. This sounds like where we find those really acute, critical causes we see in the ICU or maybe the trauma bay.
Yeah, this category demands immediate recognition because the calcium drops fast and often dramatically. The prime example of chelation is citrate toxicity during massive transfusion.
From the blood products.
Right. Citrate is the anticoagulant used in banked blood. When you transfuse large volumes rapidly, that citrate floods the system and binds up or chelates the circulating ionized calcium, pulling it right out of the active pool.
And precipitation.
Precipitation happens when you have a massive, rapid release of phosphate into the bloodstream. Think tumor lysis syndrome, severe rhabdomyolysis, or acute kidney injury with phosphate retention.
What happens then?
That huge phosphate load basically forces calcium to bind with it. Forming calcium phosphate precipitates that deposit in tissues. This just sucks calcium out of the serum, leading to profound hypocalcemia.
So, stepping back, it seems like magnesium is a recurring theme woven through many of these causes.
Yeah.
We said low magnesium impairs PTH secretion. How vital is checking and correcting magnesium levels?
It's absolutely foundational. You simply cannot treat hypocalcemia effectively if you don't address hypomagnesemia concurrently. Because magnesium deficiency hits you twice. It impairs PTH secretion, and it blunts the action of PTH on its target tissues. So if your patient is severely hypocalcemic and hypomagnesemic and you only pour in calcium,
it won't work well.
exactly, the patient will likely get little benefit, or the calcium level will just crash again quickly because the body's own regulatory system, driven by PTH, is offline. Magnesium must be checked immediately and repleted aggressively alongside calcium. It's often the key to restoring the body's ability to manage its own calcium.
Okay, that's crystal clear. So once we've established the diagnosis, maybe have an idea of the cause, let's pivot to the acute management protocols. These are mandatory when symptoms are present or the low calcium is severe, right? What are those trigger points for needing intravenous calcium right away?
Yeah, intervention is absolutely mandatory for any patient with clear symptoms of hypocalcemia. We're talking tetany, seizures, cardiac instability like QT prolongation, or maybe refractory hypotension.
Okay, symptomatic is a definite go.
Definitely. And we also treat marked asymptomatic hypocalcemia. The typical thresholds there are an ionized calcium less than 0.9 millimoles per liter or a total calcium less than 7.0 milligrams per deciliter. Even without symptoms, those levels pose an imminent risk of rapid deterioration.
And the treatment is intravenous calcium. We've got two main options, gluconate and chloride. How do you decide which one to use? There's a safety aspect here, right?
Absolutely. Intravenous calcium is the way to go acutely, but the choice depends heavily on the type of IV access you have. Calcium gluconate is strongly preferred for peripheral IV administration
Why gluconate peripherally?
because it has a significantly lower risk of causing severe tissue toxicity, necrosis, and phlebitis if the IV infiltrates or extravasates. It's much gentler on the veins.
And calcium chloride.
Calcium chloride packs more punch. It contains about 3 times more elemental calcium per milliliter than gluconate, but it is incredibly caustic, very damaging to tissue.
The central line only.
Strictly reserved for patients with secure central venous access, typically in really life-threatening situations where you need rapid high-dose replacement. For almost all other scenarios, gluconate is the safer choice.
Okay, so focusing on calcium gluconate, our usual first-line agent, what's the typical dosing protocol, like the one recommended by the ATA guidelines?
For the acute bolus, it's usually 10 to 20 milliliters of a 10% calcium gluconate solution. And critically, this needs to be infused slowly, usually over 10 to 15 minutes.
And how much elemental calcium is in that?
That's key to know. 10 milliliters of 10% calcium gluconate provides 93 milligrams of elemental calcium. The slow infusion is vital to prevent overshoot hypercalcemia and avoid triggering arrhythmias.
Right, that bolus helps stabilize things acutely, but calcium gets cleared pretty fast. So how do we maintain the level after the initial bolus?
Exactly. The bolus is just a temporary fix, a bridge. To stop the calcium from dropping right back down, you almost always need to follow the bolus with a continuous infusion.
What kind of rate?
A standard starting point for the infusion is around 1.25 milligrams per kilogram per hour of elemental calcium. But that's just a starting point.
Needs titration.
Absolutely. That rate needs careful titration based on frequent ionized calcium checks. The goal is to maintain stability, avoid recurrent hypocalcemia, but also prevent iatrogenic hypercalcemia.
And the monitoring during this whole acute correction phase.
Yeah.
You mentioned ECG surveillance earlier. What about lab checks? How often?
Monitoring has to be intensive, non-negotiable. Continuous ECG monitoring is essential throughout the IV calcium administration because of that arrhythmia risk.
And labs?
Ionized calcium levels need to be checked very frequently at the start, typically every 1 to 2 hours while you're initiating the infusion and making adjustments.
Every 1 to 2 hours.
Yes, initially. Once you've achieved stable levels, you can usually space it out a bit, maybe checking every 4 to 6 hours. But that frequent feedback loop is the only way to ensure the infusion rate is right.
And running in parallel with all this calcium management is the magnesium piece we keep coming back to.
Has to be. If the patient is also hypomagnesemic, you must start repletion immediately. For severe deficiency, a common approach is giving 1 to 2 grams of magnesium sulfate as an IV bolus.
And for less severe?
For milder cases or for maintenance, oral magnesium oxide or other formulations can work. But if you skip correcting the magnesium, you'll just find yourself chasing low calcium levels endlessly and unsuccessfully. It's futile without magnesium sufficiency.
Okay. Let's shift gears a bit now to the longer game. Chronic management and also some of the complexities we run into in specific patient populations. For stable patients, maybe those with mild asymptomatic hypocalcemia, say ionized calcium between 0.9 and 1.1 millimoles per liter, what's a goal of therapy?
Yeah, for those milder or chronic cases, the foundation is usually oral calcium and vitamin D supplementation. But here's where the therapeutic goal gets a little counterintuitive.
How so?
We actually deliberately aim to keep the serum calcium level in the low normal range. Not mid-normal, not high normal, but just sort of skirting the lower end of normal.
Huh. Why aim low? What risk are we trying to avoid there?
The main long-term risk we're trying to mitigate is hypercalciuria, too much calcium spilling into the urine.
Okay.
When you're using chronic replacement, especially the high doses of oral calcium and active vitamin D analogs often needed for conditions like chronic hypoparathyroidism, it's easy to push the body to excrete a lot of calcium.
And that causes problems.
Yes, significantly increases the long-term risk of kidney complications. We worry about nephrocalcinosis, which is calcium depositing in the kidney tissue itself, and nephrolithiasis, kidney stones. Both can lead to progressive kidney damage over time.
So by targeting that low normal calcium range, we're trying to protect the kidneys.
Exactly. We accept a slightly lower serum calcium level to minimize that urinary calcium load and preserve long-term renal function.
Now, for chronic hypoparathyroidism specifically, which sounds like one of the toughest forms to manage long-term, there's been the development of recombinant human PTH, or rhPTH. How does that fit in?
Yeah, that's been a really significant advance. rhPTH is approved for certain patients with chronic hypoparathyroidism who are difficult to manage with conventional therapy.
What's the main benefit?
Its major advantage is that it often allows patients to significantly cut back on those massive doses of oral calcium and active vitamin D they usually need. And by doing that, it helps reduce the risk of hypercalciuria we just talked about.
Sounds great. Are there downsides?
Well, its use is still somewhat limited. It's very expensive. And because it's relatively newer compared to, say, insulin for diabetes, there's still ongoing vigilance regarding long-term safety data. So it's reserved for specific cases.
Okay. Let's swing back to the ICU patient where all that controversy lives. We established that hypocalcemia is often a marker of severity. So does the evidence actually support routinely giving calcium supplements to critically ill patients if they're asymptomatic?
The answer, based on current evidence, is a pretty clear and cautious no. Routine parenteral calcium supplementation just for asymptomatic hypocalcemia in ICU patients is explicitly not supported by robust data.
So the studies don't show benefit?
Correct. Systematic reviews looking at hard outcomes like mortality or length of stay have consistently failed to demonstrate improvement when calcium is given prophylactically or just to chase a number in asymptomatic patients.
And it's not just that it might not help. Is there actually concern it could cause harm, especially in certain groups, like patients with sepsis?
That's the really critical distinction, yes. It's not just neutral. There is some data suggesting potential detrimental effects.
Like what?
The concern is that excessive calcium, particularly in the setting of inflammation and shock, might worsen tissue ischemia or perhaps contribute to microvascular dysfunction. This concern is particularly highlighted in the context of sepsis.
So the bottom line for the ICU?
The bottom line is extreme judiciousness. We reserve aggressive IV calcium replacement strictly for those who are clearly symptomatic or have severe hypocalcemia, defined by that ionized calcium less than 0.9 millimoles per liter threshold we mentioned. Otherwise, chasing mild asymptomatic hypocalcemia is not evidence-based and could potentially be harmful.
Okay, that's a crucial point. Now, let's drill down into maybe 4 key clinical scenarios where the guidelines offer some specific, tailored advice, starting with the patient right after neck surgery, thyroidectomy or parathyroidectomy.
Right. These patients have a very high risk for hypoparathyroidism, at least transiently, sometimes permanently. The ATA consensus here is quite clear.
What do they recommend?
They recommend using PTH levels post-operatively to guide management, but also implementing routine post-operative supplementation with oral calcium and calcitriol. Calcitriol is the active form of vitamin D.
What kind of dose for calcitriol?
The common starting dose is around 0.25 to 0.5 micrograms, usually twice a day. And the studies show that putting these routine protocols in place significantly cuts down on symptomatic hypocalcemia.
Makes sense.
And importantly, it also decreases hospital readmission rates for hypocalcemia, which used to be a big problem.
Good to know. Okay, second scenario, massive transfusion. A common situation in trauma, surgery, GI bleeds. The mechanism is citrate toxicity. What's the approach?
This requires a highly proactive, protocol-driven approach because the citrate chelation is predictable and can happen very quickly.
So protocols are key.
Yes. The American Association for the Surgery of Trauma, for instance, mandates protocolized calcium replacement. Their general recommendation is to maintain the ionized calcium level above 1.0, maybe even 1.2 millimoles per liter during massive transfusion.
How is that typically done?
A common protocol involves giving 1 gram of calcium, usually calcium gluconate for safety, with the very first unit of transfused blood products, and then repeating that dose after every 4 units or so transfused thereafter.
Why is that so critical during transfusion?
Maintaining adequate ionized calcium is crucial for the coagulation cascade. Many clotting factors are calcium dependent. It's also vital for maintaining myocardial contractility and overall hemodynamic stability during resuscitation.
Got it. Scenario 3, chronic kidney disease, CKD. This sounds complex, often multifactorial causes for hypocalcemia here. What's the main guidance from the KDIGO guidelines?
Yeah, CKD is tricky. You often have high phosphate levels, plus that impaired vitamin D activation we discussed. KDIGO generally recommends trying to maintain calcium levels within the normal range, primarily by focusing on rigorously controlling serum phosphate levels, using binders, dietary restriction, and also by addressing the vitamin D deficiency, usually with active vitamin D analogs like calcitriol or paracalcitol.
Okay, but KDIGO adds a really important caveat, right? Warning against routine correction of mild hypocalcemia. What's the big fear there in CKD?
The overwhelming fear is accelerating vascular calcification, which drives cardiovascular morbidity and mortality in CKD patients. So clinicians are specifically advised against just routinely correcting mild asymptomatic hypocalcemia. Overly aggressive correction or just inappropriate calcium loading, especially if phosphate isn't well controlled, drastically increases the risk of calcium depositing in blood vessel walls,
Leading to calcified arteries.
Exactly. So serial monitoring of calcium, phosphate, and PTH is essential. But the focus is on achieving overall mineral balance, not just normalizing the calcium number at the expense of long-term vascular health. It's a balancing act.
A critical distinction. Okay, final scenario. Acute pancreatitis. We often see hypocalcemia here, traditionally thought to be due to calcium saponification in areas of fat necrosis. Has the management thinking changed recently?
Yes, it has shifted somewhat. Hypocalcemia is definitely common in severe pancreatitis, related to that saponification process where calcium gets consumed in a necrotic fat.
And historically, we might have replaced it fairly readily.
Historically, yes. But newer data has emerged suggesting that routine calcium administration in pancreatitis patients does not actually improve mortality or other important clinical outcomes.
Really? No benefit?
Apparently not. And perhaps even more surprisingly, some data suggest it might even be associated with a prolonged hospital stay.
Wow, so what's the recommendation now?
The current thinking is that calcium replacement should be strictly reserved only for those pancreatitis patients who develop severe symptomatic hypocalcemia again, things like tetany, seizures, significant arrhythmias. For the rest, focus on treating the underlying pancreatitis.
That theme keeps coming back. Reserve aggressive replacement for severe or symptomatic cases and focus on the underlying cause. That seems to be the major takeaway across these different situations.
It really is. Treat the patient and the underlying problem, not just the number, unless that number represents clear and present danger.
Okay, let's finish up by talking about long-term surveillance for those on chronic therapy, and maybe recap the dangers of letting chronic hypocalcemia go untreated. For a patient who's stable on oral supplements, maybe someone with permanent hypoparathyroidism, what's the right monitoring schedule?
Once a patient is stable, you can usually transition the monitoring frequency. Checking serum, calcium, phosphate, magnesium, and creatinine perhaps every 3 to 6 months is often reasonable.
What about vitamin D?
25-hydroxyvitamin D levels might be checked every 6 to 12 months. But arguably, the most important piece of long-term monitoring is actively screening for that complication we keep hammering home, hypercalciuria.
Right, the excess urinary calcium. How do we effectively screen for that to actually mitigate the risk? We need more than just serum levels.
Exactly. You need objective data on urinary excretion. A 24-hour urine collection for calcium excretion should probably be done every 6 to 12 months.
And what's the target?
The therapeutic goal is to keep that excretion low, ideally less than 4 milligrams per kilogram per day.
And if it's high, or if kidney function declines?
If a patient consistently has high urinary calcium despite trying to optimize their replacement doses, or if you start seeing their creatinine rise or GFR fall, then it's wise to get imaging. Renal ultrasonography is recommended, maybe every 1 to 5 years, depending on the situation, specifically to look for early signs of nephrocalcinosis or nephrolithiasis before irreversible kidney damage occurs.
Okay, that makes sense. Let's just quickly summarize the consequences if hypocalcemia isn't treated adequately. Acutely, we know the risks are immediate and severe.
Yeah, the acute risks are genuinely terrifying. Tetany, which can progress to laryngospasm and airway closure, seizures, that dangerous QT prolongation leading to potentially fatal ventricular arrhythmias. And in the critically ill, we know that persistent, uncorrected ionized hypocalcemia is linked to hemodynamic instability and that higher mortality risk.
And then the chronic consequences. They might be more subtle initially, but they sound quite debilitating over time and really require that long-term vigilance.
They really do, and they affect multiple organ systems. Chronically, we can see those neurological issues like calcifications in the basal ganglia, the development of premature cataracts, or even that papal edema picture suggesting pseudotumor cerebri.
And effects beyond the CNS.
Yes. The chronic mineral dysregulation, often coupled with the secondary hyperphosphatemia that can develop, leads to impaired bone mineralization, potentially osteomalacia or rickets. And then there's the kidney damage from the cycle of hypercalciuria, leading to nephrocalcinosis and progressive renal impairment over years.
So definitely not benign long-term. Before we wrap up, we have to acknowledge something you alluded to earlier. Despite having these guidelines, the sources themselves point out some persistent evidence gaps that still limit our ability to treat with absolute certainty.
That's absolutely right. It's kind of remarkable given how common hypocalcemia is and how physiologically important calcium is. But much of our current practice, especially regarding precise treatment thresholds, still relies heavily on expert consensus and observational data.
We lack the big trials.
We really do. We lack high-quality, large-scale, randomized controlled trials that definitively tell us the optimal calcium replacement thresholds for the general hospitalized patient, and maybe even more importantly, for specific subgroups like the critically ill.
And that uncertainty reinforces.
It reinforces why we have to keep emphasizing individualized assessment, why we have to aggressively hunt down and correct the underlying cause. Is it magnesium? Is it vitamin D? Is it PTH failure? Rather than just reflexively giving calcium based on a number alone.
Okay, so synthesizing this whole deep dive. Key takeaway number 1. Always use ionized calcium for an accurate diagnosis, especially in sick patients.
Absolutely non-negotiable.
2. Aggressively treat patients who are symptomatic or severely hypocalcemic using that ionized calcium less than 0.9 millimoles per liter or total calcium less than 7.0 milligrams per deciliter as a rough guide. Use IV calcium gluconate preferentially for peripheral access. Monitor the ECG continuously.
Right, and don't forget point 3. Concurrent aggressive correction of any underlying magnesium deficiency is mandatory for treatment to be effective.
Got it. And the big cautionary principle, especially relevant for hospitalists and intensivists.
Be extremely judicious with calcium replacement in asymptomatic critical illness. The current evidence warns that routine parenteral supplementation in this group likely doesn't improve outcomes and carries potential risks, particularly in sepsis and maybe CKD.
Which leaves us with a really provocative question, something for us and our listeners to think about and perhaps guide future research. We highlighted that paradox, right?
Yeah. The paradox that failure to normalize ionized calcium in the ICU within about 4 days is associated with worse mortality.
Yeah.
Yet, just giving routine parenteral calcium supplementation to everyone doesn't seem to improve overall outcomes.
So what does that paradox suggest?
It strongly suggests we're currently failing to discriminate effectively. We're likely treating a mixed population. Future research really needs to focus on identifying that specific subpopulation of non-responders, those patients for whom hypocalcemia isn't just a marker, but is actually a direct remediable driver of their poor prognosis.
As opposed to
those patients for whom the persistent hypocalcemia is purely a reflection, a marker of overwhelming, probably non-survivable disease severity, where giving more calcium won't change the outcome.
Finding that specific cohort, the ones who truly benefit from aggressive, targeted calcium therapy.
That's the challenge. Identifying them will be key to developing the next generation of truly evidence-based, personalized hypocalcemia protocols in the hospital.